Actually, we do have four possibilities, four techniques. Pre-ERCP plus cholecystectomy, preferably laparoscopic one. The second one is SCDB, SC plus laparoscopic CBD exploration, and we will see it. The random technique, so SC plus intraoperative ERCP, and at the end, LC plus postoperative ERCP. But this is our study, the study I'm going to present to you, that Professor Ricci published in 2018 in trauma surgery. And this is actually the comparison of the four techniques. That's why, because in a place like this, in a room with students, while he was teaching how to deal with this kind of disease, the students just asked him, but which one is the best? Is there any reviews, any study in the literature that was able to compare different techniques? Well, the answer was no. So that's why this is the reason of the study. And I think it's very actual. So what we're talking about, this is the disease we have to treat. So if a patient, elective or an emergency situation, with a gallstone disease and the stone CBD. So we need to clear the CBD and have the gallbladder. So for surgery and for surgery on residents, the important thing is how to perform LC. If you want to reduce the risk of EDI, you must know the epicystic triangle and the color triangle and achieve the CVS, the critical view of safety, during your surgery. I did have a video that unfortunately I cannot show you. This is the first LC of Professor Rich.
My first question.
Yeah. So I will just explain. Okay, so just a quick reminder for us. Everyone is teaching us from the first year of residency how to perform SC and CBS. So which is the point? And this is my sources, is to 2020 USAS guidelines that we need to use in order to reduce the bile duct injury again. So the use of the CBS during LC is a strongly recommended approach to minimize the risk of EDI, as I already said to you. But what if I'm not able to reach the CBS? So then we go to bailout procedure. I will give you a tip with a source, a good source. So we do have many bailout procedure. First one is STC, so a subtotal cholecystectomy in a different way, and it depends on the clinic, on the type of gallbladder we are approaching. But the other technique we can use when we start on LC, we could go on a conversion to open, but careful because it depends on the exercise of the surgeon. So there is insufficient evidence to support conversion to open as a strategy to avoid and reduce the risk of EDI, because maybe if you are more confident with a laparotomic approach, then okay, you go to open. But if you are maybe more expert in LC and laparoscopic surgery, maybe you should try to go with a bailout procedure laparoscopically. This is an image from this source. You can just read it, and we you have many types of weight loss techniques. So, as I already told you, we are approaching two problems. We are approaching two problems. So, the gallstone, and now we have to clear the CP. This is an algorithm how to check before the surgery, before going to surgery. Because I mean, the main aim to perform this kind of procedure is to go into the operating room, already know how is the anatomy of the biliary tract. So if you're able to, you should know how many stones, what kind of stones, the size of stones inside the biliary tract. I want to stress this point because, for example, it could happen that maybe you just bring the patient to the operating room with a very old imaging, and you don't know, maybe you will find a malignancy syndrome. So when the gallbladder is completely fused with CT, and it could happen. So again, which is the best technique for surgical management of the gallstone? I want to stress one by one. The first one we approached that we would find in our study was the preoperative ERCP analysis. Those are pros and cons. You will see it in the image as cons. Pros and cons are preoperative ERCP and okay, that's one. I was looking at that. So the main aim is to perform cholecystectomy within 72 hours of ERCP 2 million. You can read here the process recurrent by biliary event prevention, a short total hospital stay, a single admission, and a wide availability. The very important cons is ERCP induced inflammation. That brings you to have many more complications subsequent surgery. That means like the inflammation that follow ERCP creates in a tissue patient progressive adhesion formation. So it increases the risk of not achieving the CPS and having many adhesion all around. Another important thing is that bacterial colonization and the risk of ERCP acute pancreatitis. This is the worst technique that increases the acute pancreatitis. And of course, higher conversion rates to open surgery when you start with LC. And this is the source. Here I have another review. This is the second. This is the second technique I will show you. Again, with pros and cons. This is the LC and non-viral aspiration. I have a video I will share this. It's very interesting. This is a surgery that gives you the possibility to do the clearance of CBD at the same time as LC. That means that, like a important cons is the technical challenge because we need advanced laparoscopic skills and suture expertise, a lot of time, a lot of learning curve, and of course like technical related challenges and biologic-related complications. But the pros are clinical effectiveness and a short hospital stay. The third one we're analyzing is a rendezvous technique, the one we call rendezvous technique. That means LC plus in same time intraoperative ERC. As you can imagine, the pros are many. Significantly lower post-ERCP pancreatitis risk, better success rate, reduce endoscopic time because you're doing like a team with endoscopies, and cost effectiveness with fewer readmission rate, and of course for the patients in the anesthesia station. The cons, you can imagine you need a team. Require high surgical endoscopy coordination and expertise, and higher technical complexity, also a longer learning curve because you have to work on the endoscopies too in the same time. The last one we will check in our graphics and in our study is the LC plus postoperative ERCP, and this is recommended ERCP with 72 hours post LC. Again, the pros and cons. For the pros, widely available, flexible time with no urgent flows, just as any other technologies or stuff. Easier LC dissection because you could achieve a CDS because you don't have already did the ERCP, so no information issue around. What about the cons? The delayed CPD clearance and the risks, high risk of cholangitis and pancreatitis, and of course increased overall cost because maybe it will need a longer hospitalization of the patient. So when we decided to write this study, we had this question. We need to answer this question: how to statistically compare full body techniques. This is not very. It's a difficult study to organize because we try to use this kind of method. The method is called network meta-analysis that starts from transitivity properties. So if it stands for if A has this common node with B and B has the same with C, then we could say approximately the same relation between A and C. We made the same thing with the study, so we achieved the study between our study. Here you can see 4 arms. Our study. Here you can see 4 arms, so the 4 different techniques, and the relative supra and rectally. The success rate, this is our outcome of interest we use. We explore, we study the adaptation we use. So we go deep into the success rate, overall morbidity, mortality, the risk of pancreatitis, the bigger relief after LC, the overall bleeding, operative time, and tolerance. So as you can see here, if we set the supra, or what is supra and rank me, the best option we found it was LC plus ERCP. So the random technique. For materials selected, those are our data sources. We use 20 randomized controlled trials with a huge number of patients, more than 2,040. And to study, we conducted the latest frequentist random effects network analysis. So what I was saying is now it appears very more difficult to understand, and also if I had my professor to explain to me. But we can just resume everything with this diagram. So what does it mean that we compare 4 surgical techniques with all these details I've already told you, but we can just summarize with this graphic that puts on the country efficacy and safety. So what do we found is that LC plus ERCP as a tool before therapy is the best option for the patient. So those are the conclusions. reality of the fact is, even if we found in Italy that red group would be the very best, we have not already used this kind of technique every day because it's as I already told you, it requires a very good and synchronous team, and we don't have always. So, like for example, in our center, it's quite difficult if you used to do ERCP first, so to clean the CBD, and then go to LC, and then go to the programmation of the surgery, because in our hospital it's not so easy to have this kind of team. So I would leave the recommendation would be rendezvous, of course, is the best choice. But all techniques have similar modality as you could read in the pros and cons graphics. And in the actual world, I think that every center should invest in ERCP proficiency for endoscopies, and maybe improve with the
I try to stimulate the discussion. Okay, this presentation is a nice presentation, and 2-3 points. First, do you know meta-analysis? This type of study. We have experience with meta-analysis. Do you know the study, meta-analysis, the type of study, kind of study? Meta-analysis is different from other study. Why? Why? Because it's a combination of study. In a meta-analysis, I use study conducted by other group, and I aggregate the data. But this is a particular type of meta-analysis. Why? Because we have not two comparators, A versus B, B versus C. I have multiple comparators. It's very difficult to integrate the. So when you have a problem, you need to search the solution of the problem. I search the solution in another field. I search it in Google, and I try the network meta-analysis about psychiatric drug. I remove from my mind the concept of psychiatric drug, and I put outside the context the methodology, and I use the methodology in my context. This is the first lesson. Okay. The second clinical message. No. The second clinical message is the evidence is on one hand, and the clinical practice is different.
Sometimes, like I told you in our center, I mean, the professor said with this study, the best option is rendezvous, but in our center we do not use rendezvous so often because it is not so easy to find always a team.
Do you have a possibility to perform ERCP? Do you have a possibility? No. Okay. But in the next year, probably, do you have the possibility to perform ERCP? So, it's a real possibility. So, this is the problem. ERCP before, during, or after surgery. The question depends on the evidence, okay, but the organization of neuroscopy. Ilaria talked about the integration of two teams. In Italy, ERCP is performed by gastroenterologists. The stomach cholecystectomy by surgeon. So we need to integrate two teams. It's not so easy because the team of endoscopists have many patients to treat in endoscopy rooms. So it's very, very difficult to integrate. In how which performed the RCT, the endoscopy, the surgeon or the gastroenterologist?